and turn this over to Susan and Amy and get started. Amy, you should have control.
Okay, thanks, Amy. Well, I'm Amy Tepp. I'm a partner here at Eide Bailey in the revenue cycle area, and I will be joined today by Susan Brody, who's a senior manager here at our firm and works in our revenue cycle group. And she also leads up our professional coding area. And we're happy to have this chat with you today. So what we did is we went through the current OIG work plan, and I kind of had looked at, because it's a living document actually, anything that popped up as active as of August of 2020. And then I went back to all the way back to June of 2019, and just sort of gleaned from that things that hospitals may want to include in their annual plan or consider for inclusion from a compliance perspective. I then broke it down by things that were COVID-19 related as opposed to other things, and we'll also talk about some of those other things that are in the work plan that are not COVID-19 related. Then we're going to talk about, what else is going on outside of the work plan. That should be some things for you to consider, what's going on out in the healthcare community. Susan's going to then provide an overview of the 2021 E&M guidelines and how they may impact your annual audit plan. If you bill for providers, these are new and significant changes from things that have been set up for quite some time. So again, with anything new, it's something that you're going to want to potentially think about. When might we want to touch base and see where or if we have any sort of issues as it relates to the implementation of these new guidelines. So we're going to move into the OIG work plan initiatives, and I'll tell you up front, I kind of used my revenue cycle hat, my reimbursement hat, and my compliance hat when I was looking at these things. This is just a sampling of things that I wanted to call out to your attention. There's many, many items out there, obviously, to look at. And again, we started with August of 2020, and we went back as far back as June of 2019. And the reason for that is, we tend to provide this as sort of as an update annually, and I know that we did something like this about a year ago, so I thought at least we'll go back a year and highlight those things for you. So the first thing, the first items are COVID-19 related, and the first one that I brought to my attention and wanted to bring to yours is audit of Medicare payments for inpatient discharges billed by hospitals for beneficiaries that are diagnosed with COVID-19. So Section 3710 of the CARES Act directs the Secretary to increase the weighting factor that would otherwise apply to the assigned DRG by 20% for an individual who is diagnosed with COVID-19 and discharged during the COVID-19 public health emergency. So the OIG has noted that they are going to audit whether payments made by Medicare for COVID-19 inpatient discharges that fall into this category, that the hospitals complied with the federal requirements. And so knowing this, what we would suggest is doing a small sample initially to review some of these types of discharges to see if you even have any sort of issue with that, which might, if you do see something, maybe then you need to do a deeper probe with that. But that's something because, again, you're going to get higher reimbursement. Obviously, they're going to want to make sure that all the coding and other compliance factors were taken into consideration for those higher payments. The next item under the COVID-19 is audit of the CARES Act provider relief funds. Now, was general money, and then there were targeted distributions to hospitals. So and this includes the Paycheck Protection Program monies as well. Over the time, there was well over $175 billion for the provider relief funding, to help facilities during this COVID-19 time, especially when volumes were so low. We had to stop doing what they considered elective procedures, which kind of turned into mainly, unless you needed it as an emergency, things were not really being done, and people weren't going and having, things that you could have waited maybe another month or two to have done. And there were monies distributed in a variety of ways. The first being where we just had something show up in a checking account or some sort of account that we have on file with the government. That money was based on the 2018 net patient revenue, and you just got that money. It wasn't necessarily, but you then had to then, say we'll comply with some terms and conditions around that. There's other money that was targeted distributions. The government carved out different pools based on what type of provider you were. Do you see it? Are you a DISH provider? You see a lot of uninsured and indigent. Are you a skilled nursing provider? There were certain segments of funding that was available to some other types of provider groups. And if you did receive money as part of that, you needed to fill out and again attest to some compliance with terms and conditions as a result of receiving those payments. We highly recommend that you look at those terms and conditions that you attested to make sure that you are complying with those things. And that's exactly what the OIG is going to do. They're going to do a statistical sample of providers that received both general and targeted funds. And they're going to, target and look at some of those payments. Some of the things, something that's sort of kind of buried in those terms and conditions is that you will not surprise bill these patients with COVID, and that you will not do balance billing. And the balance billing applies to those things where you used or maybe submitted claims to that uninsured portal. So balance billing means that you accepted that payment, which is I think was based on Medicare payments, and you can't bill the difference between what your charge is and what you received as part of the payment for that. Surprise billing, on the other hand, is that, which maybe I'm a patient and I had an anesthesia provider that was part of my care during this time, and I didn't know that that provider was not in my network. Well, we can't surprise bill as a, out of network for that and make the patient pay any additional charges relating to that. So that gets kind of tricky because everything's so automated these days. So it might require a deeper dive into how are we safeguarding to see that we're doing that so that we can comply with that the attestation. The next thing is telehealth services. Telehealth really became a big deal. If you weren't doing it before, you're doing it now, and in a greater volume. And so what the OIG is looking at is, what extent did our Medicare beneficiaries utilize telehealth services as opposed to face-to-face visits? And then they're going to look at any sort of program integrity risks with Medicare telehealth services, mainly to ensure that the reimbursement was appropriate. During the COVID-19, initially, so many everyday stuff was coming out about what is telehealth, what's an e-visit, what's a virtual visit. which is Medicare's terminology. Other health plans have their own terminology. Things were changing rapidly. So just a matter of understanding and making sure that those payments, you know, that the, you know, whatever technology you were utilizing complied with what they were, you know, the underlying technology expectation of that charge, and that you were complying with the rules and regs. And Susan's just going to talk a little bit more about some other things going forward with telehealth, so I'll have her talk about that right now.
Great, thank you, Amy. Just can we advance one slide? Thank you, thank you. Oh, I apologize, this is very small handwriting or very small print. I know we just wanted to get all the information on one page, so we did break it out and color code it. But in response to the pandemic, the coronavirus pandemic, CMS had to make a number of changes so that we could allow those Medicare beneficiaries to access these telehealth services without having to travel to a healthcare facility, because that was the whole point of, you know, doing this telehealth, so they wouldn't have to go into facilities. A lot of the changes are currently temporary, but what CMS is willing to do is explore some options to see if these services should be extended, or they should go back to being temporary, or if it should just go back to how it was pre-pandemic. So they're going to do 2 concurrent reviews based on some data that they've compiled. The first review is going to examine the extent to which the telehealth services are being utilized by these Medicare beneficiaries, and how the use of the services can compare to some of the other services that if they're delivered face-to-face. And then the second part of the review will identify any risks that may come with these Medicare telehealth services to ensure that their appropriate use and reimbursement is being done during this COVID pandemic. And you can see in black, those are services that CMS is proposing to make permanent. And that's group psychotherapy, some of that domiciliary and rest home. And you can see that in home visits comes within all 3 sections. But if you look at the actual CPT codes, the black level, those are low level codes for home health and rest home and custodial care. And as you go, the red become a little higher, and then the blue are the highest level codes. And that's why you see that on there more than once. The codes that are there in red, those are what are being proposed to be temporary additions. And then the ones in blue are codes that they're waiting for. They're seeking comments from other health professionals to see, do we want to make these permanent? Do we want to leave them temporary throughout the rest of the PHE? Or do we want to go back to how it was prior to the pandemic? Unfortunately, we don't have any date set, so we know when the PHE is going to end. We have seen some documentation stating that it could be in December, but again, we just really don't know. So I think it would be appropriate if you printed this off. Hopefully you can make notes of which codes go with which, because I know it does get kind of tricky. And then you can look at that and see what your coding falls under on this. And now I'll turn it back over to Amy.
And continuing with our theme of COVID-19 OIG work plan items, the next item is controls over the expanded, accelerated, and advanced payment APP program and recovery. And so this is, you know, to the extent your hospital even participated in this program, this would relate to something, although the focus is really going to be the OIG looking at CMS and how they you know, executed the program and how they're recouping the money. It probably is worth taking a look at to ensure that you are following that you've got a process in place around the recoupment piece. I do know that as of last week, we had heard that there is at least one MAC out there that communicated to a hospital association that, you know, CMS has kind of told them to hold on, don't start recouping these payments yet. They're waiting further direction from CMS, but you know, it's going to happen, and once it happens, just to make sure that you're complying with that. The other thing is, to the extent that you have a skilled nursing facility Nursing homes were required to, as part of the communicable diseases reporting in nursing homes, they are supposed to be reporting in standardized format. Then this includes COVID-19 during this public health emergency. So the OIG is going to be reviewing to see if nursing homes have been doing this, that it's been complete information, that it's accurate, and that it's reliable. The other item is the OIG is going to be doing some trending analysis, albeit it's just a data thing. That's just going to provide them information to see if there's something else they need to do. But what they're going to be looking at is they know that there's been some relaxation during this pandemic as it relates to physician ordering and NPP ordering of certain add-on tests to the COVID-19. And this relates to the study or relates to respiratory pathogen panels or RPP tests, allergy tests, and genetic testing. So it might be something that you might want to look at incorporating some sort of data analytics around those kinds of add-on tests to see if you maybe have any sort of spikes or things that might kind of stick out that you may want to take a further dive into. Now, here's some other things that don't necessarily relate to COVID-19, but we've seen them on and off sometimes on the OIG work plan, but some of them are new. And I'm going to talk about a couple, and then we're going to have Susan weigh in on a few of the other ones. But the first one that I wanted to talk about is Medicare bad debts. This is something that's been on the work plan before. I know hospitals have been audited before on this, but it's something maybe to revisit if you haven't looked at it in a while. So as you know, hospitals receive additional reimbursement for their Medicare bad debts, which is the uncollectible, deductible, and coinsurance for Medicare beneficiaries. And once the hospital has established a reasonable collection effort, they've deemed the debt to be uncollectible, and that there's no likelihood of future recovery, they can report it as a bad debt to Medicare and then claim it on their cost report. So the OIG has stated that they're going to select a sample of hospitals, that they will review policies and procedures in collections, as well as the policies around offering of financial assistance. How do they identify bad debts in their organization, and how do they account for receiving money on a previously reimbursed bad debt? They're also going to look at a sample of claims that are high dollar amount. So something to consider as part of potentially incorporation into your annual compliance plan. The other item I wanted to call out again is something that's been on this and has been an issue and out there for years. It's around the transfer DRG piece. The reason being, you get 100% of the DRG payment if you call it a discharge, excuse me, as opposed to if it's considered a transfer. The transfer payment, then a portion of that, you only get a portion of the DRG payment because they're going to another facility to get the rest of their care. So again, something to take a look at to see if there's any potential issues with that, or you understand we have a great process around this piece, but just something to incorporate potentially into your plan. And I will now turn it over for Susan to finish up on the last few items on here.
Great, thank you, Amy. So let's first talk about the Medicare payments to physicians for post-surgery procedures. If you follow the active work plan, it's from March 2020. And what happened here is there's certain procedures that do require two surgeons. They need the individual skill of two separate surgeons. The one that instantly pops into my head is if you do any extensive back surgeries, there typically will be one surgeon that will do the approach and the closure, and then one surgeon that will actually do the procedure on the spine or the back. Now, these procedures are reported. Each provider should report the procedure with the 62 modifier. And what the OIG is going to do is they plan to audit just a sample of some claim line items, specifically where different physicians billed the same procedure code on the same patient on the same date of service, excuse me. And their objective is to determine whether Medicare Part B payments to both those physicians were properly made. This came right when COVID was hitting, so I would assume that this might get pushed back, although I'm very curious to see the results of this one. The next one, we'll talk a little bit about Medicare facet or facet joint procedures. This goes all the way back to August of 2019. There were several reviews done on these codes, including one done by the OIG where they noticed massive overpayments. So what they're doing is simply going back in, they're going to review whether payments made by Medicare for these procedures that were billed by physicians complied with federal requirements and were properly made. This continues to be a hot button topic. Typically because documentation needs to be there to support these codes and not to support if they were done transforaminally or interlaminar or epidural. They need to be the facet or the facet joint that is being injected. The third one that we'll talk about is that Medicare payments of positive airway pressure devices or CPAP for obstructive sleep apnea without conducting a prior sleep study. And this goes all the way back to that August 2019 one as well. There was also a CERT review done on this, as well as an OIG review done on this particular item as well, where they did notice quite a few errors. So Medicare is saying they want to make sure that they're paying for the DME correctly for that CPAP machine, if it was reasonable and necessary, and how some of these places determine that without doing a prior sleep study. I think that's the most important piece of this is how did you know that the provider needed the CPAP if you didn't do the obstructive sleep apnea study first? And then that last one, it applies to the Substance Abuse Mental Health Services Administration, or we typically just refer to that as SAMHSA. They did receive quite a bit of money in the form of grants to provide help to patients during natural disasters, such as, let's just say, hurricanes or tsunamis or anything like that. This one really isn't related to COVID, but they got that money and it was supposed to be used for crisis counseling, helplines, things like that. And so what the OIG wants to do is maybe just do a little fact check on SAMHSA to make sure that the money is being properly allocated. This one came about in March of 2020 as well. So if I was a betting woman, I'd say it's probably on hold for a bit due to COVID as well. All right, now we're going to get into the 2021 evaluation and management, or we'll just refer to it from now on as the E&M, coding and documentation changes. So what we know about this is that if you've been around a while, the E&M code guidelines have not changed since 1995. That's quite a long time, considering that we get code updates all the time. There was a brief change to the documentation guidelines in the form of the exam in 1997 to make it easier for some specialists to achieve a higher level exam. But that's basically all that's been done since 1995. So we really were due for some changes. What CMS hoped to accomplish here is to alleviate some of that administrative burden. And what the providers are liking to call this is the Patients Over Paperwork Act, meaning they just want to see their patients. They do not want to be worried about if they hit every single bullet so they can get the appropriate code. And this is supposed to help with that. It also is meant to maybe prevent some erroneous documentation, because one thing that we do know is with the advent of the EMR, or the electronic medical record, there's a lot of copy, pasting, canned, clone documentation. And the more documentation you get, the higher the risk for some of that erroneous documentation becomes. One point I hope you leave today knowing is that this only applies to Medicare. Now, we know historically that payers typically will follow Medicare suit, but not all of them. So we do not know right now if commercial or Medicare Advantage or state Medicaid will follow. You will have to follow up with those payers. I do know that Blue Cross Blue Shield of North Dakota has already come out saying that they are going to follow these guidelines, but that's the only one that I know definitively as of right now is going to. But like I said, historically, they do typically follow. So I would assume that they're going to fall in suit or fall in line, but check with your payers on that. These will only affect clinic E&M visits. So these will not affect your ERs, your inpatient, your observations on the professional side, only your clinic visits. So that's your 99202 through 99205 for your new patients, or 99211 through 99215 for your established. Now you'll notice I didn't say 99201, the lowest level new patient visit we have now, because that's going to be deleted. And that code is deleted because its medical decision making and 99202's medical decision making was identical. So there was no need to have that same code. It would just be duplicative and we didn't need it. So they did delete that. Now you're probably thinking maybe, oh great, I can just forget all those rules about 1995 because there are a lot of rules, but you do still need to understand them if you are coding for the professional side in the ED or the nursing home inpatient observation, as they have not followed suit yet. But again, what we know historically is once CMS starts something, and this is probably going to be the guinea pig, if it goes over well, we tend to see it follow all the other places. So I would say within a few years, these guidelines will trickle down to these other places as well. All right, this is just a high level discussion on this. My email is at the end and my phone number. So if you have any other questions, please feel free to contact me. But what basically is going to happen is the history and the exam component are going to go away. And we will now be choosing the codes based on medical decision making, not to be confused with medical necessity, but medical decision making or time. Now, CMS still would like the providers to do some sort of medically appropriate history and or exam and to document that, but it's really not required. What is going to be required is the documentation of how you got to your medical decision making or your time. All right, so the modifications that came to medical decision making weren't huge. There was the removal of some terms that were super ambiguous, like mild or acute or chronic illness, because those are very subjective. And as coders, we're taught we're not providers, so we should not be the ones determining if somebody's condition is mild or if it's acute or chronic, if the provider's not specifically stating that in their documentation. It also defined some terms in greater detail, such as independent historian, etc. We do know we talked about the deletion of code 99201. They agreed to delete that because it had the same medical decision making as 99202. So then that would just be two codes of the same thing. So they just got rid of that one. And then they created a prolonged care code that is shorter. Typically the prolonged care code started at an additional 30 minutes. The new code that they're creating, which is a bunch of numbers and letters, I'm not sure if it's final yet, so I didn't want to put it in here, but it would be based off 15-minute increments with the caveat that it can only be applied to the two top level codes. So the top level codes for the established patient of 99215 or the top level code for the new patient, which is 99205. Those are the only codes you can add that prolonged care code onto, which does make sense, but as of right now, the prolonged care codes that we have, you can put them on any E&M. But this does make sense. If we're gonna be billing on time, obviously, if we hit the top threshold, then we can add this prolonged care code onto it. Now, this is just a little grid that the AMA, or the American Medical Association, put out, and it just kind of shows you the difference between 2020 and 2021. So in 2020, it's the number of diagnosis or management options, and in 2021, it's the number and complexity of problems addressed at the encounter. In 2020, it's the amount and or data of complexity complexity of data to be reviewed. And in 2020, it's the amount and or complexity of data to be reviewed and analyzed. So as you can see, there's not huge changes in the medical decision-making, which is great because that is the hardest part of coding to teach. So if you already have a good grasp on your medical decision-making, you should be fine with the new regulations. This is the medical decision-making table that the AMA put out. Again, I understand it's very tiny, but I did include a link, so you can click on that link and you can download this and you can laminate it and you can carry it around because it is really quite helpful. And this next slide, hold on, I don't think it liked me, Amy, because it's just spinning.
All right, let me see if I can move it for you.
Thank you.
There you
Yep,
go.
there we go. This is a medical decision table, making table. It just shows you that as right now, you need 2 of the 3, and that continues forward into 2021. So we always will take the average. So we'll get rid of this low one and we'll take the average of these 2 higher ones, and that's how we'll come up with our level. And that's the exact same as what we're doing right now. This just kind of shows you in detail. There we go. And this is just the link that I was telling you about. So if you click on that link, you can get that MDM grid up and again, laminate it, put it in your pocket, carry it with you at all times, because it really, truly is pretty helpful. All right, so that was the medical decision-making portion. Now, the other way that you can determine your level is by using time. And in 2020, if you were going to utilize time to pick your level, the time had to be 50% counseling and coordination of the total visit time. So if your visit total time was 60 minutes, at least 30 minutes of that had to be counseling and coordination of care. And you had to show that in your documentation. And it really was difficult to prove. Towards the end, a lot of providers were just simply saying 30 minutes of the 60 minutes was counseling and coordination of care. And then you couldn't determine from the note if that was actually accurate or not. Well, now it's just going to be total time of the visit that the physician or other qualified healthcare professional or QHP spent doing any of these following activities. Preparing to see the patient, so reviewing of old tests. I recently did a review where the providers had Epic and they said, every time I'm gonna see a patient, I go back 1 visit, I look at everything before I even see them. Well, that time would count. Obtaining or reviewing a separately obtainable history. Performing that medically necessary exam or history component that we talked about earlier. Counseling or education, that hasn't changed. Ordering meds, tests, or procedures. Referring and communicating with other healthcare professionals. Now, if there's a separate code for this and you're assigning that, then it can't go towards your time. But again, I did a review and where an oncologist said, sometimes I have to step out of the room and I have to call another provider related to this patient to ask them a question, or I need to call down to radiology to ask them a question about a CT scan the patient had. And I might sit on the phone for 10 minutes. Absolutely, that time counts. Documenting clinical information in the EHR. This could get to be a slippery slope because we do know some people may be quicker than others at entering that information, and how would you even prove that? Independently interpreting results if you're not assigning a separate code for that. And then any of that care coordination, again, if you're not assigning a separate E&M code for that, that can be counted in your time component. So it really is quite liberal in what can be included in your time component. Now, with that being said, CMS realized that, and they did up the typical times in the year 2021. So this grid just shows you with new patients how the times have changed. Now we know that 201 has been deleted, so we'll go to 202. Typical time in 2020 was 20 minutes. Typical time in 2021 is 15 to 29 minutes. And then you can see it goes up. So the 205 used to be typical time 60 minutes. Now it's 60 to 74 minutes. And if we want to use that prolonged care code time, we can only use it on 205, and it doesn't start until you get to the top of that threshold, so 74 minutes. And the same can be said for the established codes, which are here. So if we just want to look at that 99213, which is probably the middle of the road typical code, 15 minutes. Now it's 20 to 29 minutes. And that 215 used to be 40 minutes. Now it's 40 to 54. So you really are seeing that jump in the middle of the road code, which I would say if you're following a regular bell curve you probably have the most of in your clinic, that's really going to take a hit right there as far as time goes. All right, let's talk just briefly about medical necessity. Again, not to be confused with medical decision making, but CMS has stated over and over that medical necessity is the overarching criteria when choosing a code. And what this basically means is just because you have 5 pages of documentation does not mean that you automatically get the highest level of code. They prefer quality over quantity. There has to be a medically necessary reason that you're seeing the patient. And where this comes into play with your electronic medical records is if a patient comes in for their ear is just throbbing and it hurts, it's just painful and it's red, and then we just click a button and our review assistance auto-populates all normal, and then we click another button and it auto-populates for our exam entirely normal. Well, if I'm reading that and I see there's nothing wrong, there would really be no medically necessary reason for that patient to be seen, and a code should not be assigned. So the body of the documentation should match what the patient is coming in for, and there should be medical necessity to be seeing that patient. And then the canned and the cloned verbiage. Per CMS, cloning is just basically when every single note looks the same. We're pulling some same documentation forward for every single patient, and they really obviously frown on that, and that did become such a hot topic with the advent of EHRs. EHRs were great as far as speeding up things and making things more accessible and easier so everyone can see the note, but with them did come a few issues, and this is definitely one of them. We want to definitely shy away from using this canned and cloned verbiage. So basically a high-level overview, the changes only apply to office and outpatient E&M services, those 99202s through 99215. You have to continue to use the 95 and 97 guidelines for your EDs, your inpatients, OBS, nursing homes. They only apply to traditional Medicare plans. We'll have to contact our other payers unless North Dakota Blue Cross Blue Shield, they've already sent something out saying they're gonna follow this. CMS doesn't have authority over other payers. However, these changes are in CPT. So if they're following CPT guidance, then they need to follow these rules, which it gets very confusing because CPT is actually put out by the American Medical Association and not by CMS. And then you can solve some issues by utilizing some different templates, and we'll talk about that in the next slide. So what can your facility do? You can update, revise, delete some of the templates that you have right now, because I'm assuming the templates you have right now have that history component and that exam component. And with the deletion of that, or only having to document a medically necessary history and exam component, we wouldn't need all of that verbiage in our templates. So we can get rid of that. And then we can eliminate that copy and paste functionality, because we need to remember that medical necessity is the overarching criteria, and we don't want any of that copy and paste documentation in there. All right, now we're going to talk a little bit about some proposed MPFS rule considerations. And these are actually bills, and the S stands for Senate. So if you see some bills that are like HR, number, that's House of Representatives. These are actually proposed bills that are in the Senate. So the first bill is S.4230. That's the Telehealth Expansion Act of 2020. And what this act would do is it would remove the geographic restrictions for Medicare patients for all of the E&M codes, not just some of them, but for all E&M codes. And then categorize those mental health services as E&M services in order to get those covered by telehealth for Medicare patients. And the next one, this is again a bill in the Senate. It's S3998, and that would improve telehealth for underserved communities in 2020. And what this would do is simplify payments for telehealth services furnished by FQHCs and RHCs, and then increase the limits on payments for RHC services. So what we know is prior to the pandemic, an RHC could not be a distant site. During the pandemic, there was a lot of discussion back and forth, and CMS did finally come to the conclusion to let RHCs be a distant site for telehealth during the pandemic. So what this bill is going to do is to see if we can make that permanent or not for those FQHCs and those RHCs. And now I'm going to turn it back over to Amy for some other considerations.
All right, so this is the wrap up and just some other things to think about. Number one being price transparency compliance. You know, we've got some new rules that are going into effect as of 1/1 of 2021. It was a big deal. Everybody was tracking what was going on with this up until about middle of March, and COVID hit. And I think we knew there was a lawsuit going on at the time. We're all hoping that that would have been decided in the favor of the hospitals. Well, in June, towards the end of June, we found out that did not happen, and it's in the appeal process. So then everybody's now scrambling on top of COVID to make sure that we're complying with the January 1st implementation compliance date. So just something to keep a pulse on, and once maybe throughout the year, just to kind of check in to see how that's going. Have we complied with the requirements of the price transparency rule? The other thing is, and you may already have this as an integral part of your compliance program, your annual plan, is just some ongoing coding and billing and looking at charge capture. You can do focused reviews. You can do it monthly, quarterly, periodically, somewhere in there. And just maybe select certain focus areas. It's just mainly to see if things are going out the way we intended them to. Does the documentation support what we, have showing up ultimately on the claim form? We generally see these being done as smaller samples of inpatient, outpatient, and professional encounters. And I just feel like it's a really good way to see, just kind of give you a sense of, are things going out the way we think they should? Have we captured the charges for the services? So much is automated these days, and we rely so much on these electronic systems that sometimes stuff gets changed with an upgrade or some enhancement and we didn't know it, or the scrubber hasn't been updated and there's some weird edit going on. It's just another way to just make sure things are going out the way we want them to. The other item I wanted to just touch upon a little bit is enrollment of the facility, and that would be on the 855A, and also NPI compliance. As organizations have grown, added practices, merged other facilities in, we've gotten more and more complicated and complex. And are we confident that we have the NPI set up the way we should, that we're registered with Medicare appropriately? As we've added board members, are we complying with the 855A and notifying Medicare within the time period that we're supposed to? As we add new board members and remove others, these are all things that it's very fragmented at times in organizations. We might have somebody in finance doing one piece. We might even have the executive administrative assistant for the CEO doing the license for the facility, and there's like no looking and coordinating and ensuring that things are being reported consistently among those different facets. So just something to get kind of a handle on. It's usually multi-departments that work on pieces of things like this related to enrollment, as well as accreditation, and just making sure that we're reporting things out there in public consistently. We've talked a lot about COVID-19. We know that we have the rules that were in effect before the pandemic. We have our pandemic rules, and we're going to have post-pandemic things. And all of those things, how are we going to make sure that either they've been done correctly or will be done going forward? So again, putting a plan together as things change to ensure that we're complying with what the new rules are. Another item is provider-based clinic compliance. I've seen over time, sometimes these things were all put together many years ago. We've had turnover at organizations, and we don't really know where any of the documentation is to support this. Also, maybe we need to just kind of do a, like I like to call it, a field trip and go visit some of these locations, you know, just to make sure they are currently complying with the rules around provider-based. So just something to keep in mind for that. And one other item I wanted to mention that's not on this slide is we do know that some hospitals have been audited by the OIG for credit balance reporting, and you never want to have them come in because they're there for a while, and undoubtedly they're going to find something. So again, what do you have policies and procedures in place around credit balance reporting? Do you understand the rules around it for you know, Medicare purposes? And just to get a sense of where you're at with that, just knowing that there's some focused audits going on right now.
I don't see any questions in there right now, so.
Okay.
There was one and I answered it. Is that all right, Amy?
Oh, you
Of
did?
course.
Yeah, I answered one that was about, oh, there's one more. Yeah, there was one relating to a coding question.
You want to read that?
It asked if, when it refers to the time component, if the provider has to consult with another healthcare professional, could it be a PT and an OT? And I said, it is our current understanding that healthcare professional, PT and OT falls under that umbrella, and that that would be appropriate. There's one now that says, please show that link to the info again. So Amy, can we go backwards? There it is. Also, if you go to the AMA website, they have an extensive base of information about the 2021 E&M changes, and you can definitely find that link there too as well.
Any other questions? Yes, there's one more in there from Cheryl.
Does the AMA address this specifically, or do you have another reference that does? Or Cheryl, if you're regarding the if the provider can consult with a PT or an OT, yeah, I can get some reference and I can get that emailed off. Or if Amy, if there's a way to get it to you and you get it to this entire group.
Yes, yep,
Okay.
we'll chat about that.
Okay, that's what I'll do. I'll get the information to Amy and she can get the information out.
Thank you for joining, everybody.
Have a great weekend, everyone. Thank you.
Thank you guys. Have a good one.